All right, Dr. Rhoton. Well, why don't you give us a brief introduction of why we are here today?
Well, part of this really kind of goes to what we do. Um, I've been doing therapeutic work for years, and a number of years ago, one of the things that became apparent to me was that there were a lot of areas that were not being served very well, and so we began to look at, uh, in addition to doing therapy, helping train other people to do therapy. And that kind of grew into where now we primarily do trainings and consultation with, we train therapists, we work with organizations to help them be able to provide a better quality of care for folks, particularly in the arena of trauma. So that's what we spend the most of every day working on. So that's kind of why we're here.
Awesome. So my first question would be, we're talking about why someone should be trained in treating traumatized families. What led up to your interest in working with families that have experienced trauma?
It's actually, there's kind of a multifold answer to that. Uh, I think the thing that first sensitized me to it and made me kind of want to understand it better was my own personal history. Understanding what is all this cockeyed stuff that I kind of grew up experiencing? How do I make sense of that? And then as I began to work in the field, one of the things that really impressed me was that how difficult it is to help an individual, particularly a child, heal from trauma without having a good, stable environment. And that was difficult to find because we found a good number of people that were experiencing trauma, whether they're children or adults. A lot of it is intergenerational. We have people that are struggling to do the best they can with the families that they are trying to raise, but their patterns and their habits of relational interaction are based on what they grew up with. So if that was less than optimal, then we get an intergenerational transmission of less than optimal family, and it generates its own symptoms and its own dynamics. And what I became convinced was important was being able to intervene in that some way to kind of change the trajectory of this family dynamic. In other words, I really don't want it to be handed down to another generation. Mm-hmm. And so I began to look at how to accomplish that, and that's what kind of drove a lot of the development of what we did around the training that we offer for families, which is the certified clinical trauma specialist for families. And that is really designed to give people the foundation to move a family through the treatment process. Most people, when they think of working with families, they think of working primarily with the child. And that's terrific. And we have people with tremendous skills. What we really need is people that know how to navigate an entire family through that process. And so that became kind of a fascination. How do we do that well? How do we do it efficiently? Mm-hmm. How do we do it in a way that helps the whole family be regulated better? How do we help stabilize the adults in a child's life without disenfranchising them by making them feel like we are blaming them for the problems? Because we're not doing that. They're operating usually the best they can from their own experience.
So I know you've been doing this work for quite some time. Why would you say your information is so important?
I think it's primarily because there is a lot of there's a lot of models out there of doing treatment, and there's kind of a mistaken idea in our view of things. We think if we have a better model, we're going to get a better outcome. And while that's true, when you start looking at statistics, when you actually look at comparing models against each other, if you have kind of what we call the core elements or active ingredients, if they're accounted for, you find most models work pretty much the same. So we began to move away from looking at a specific model. What, does this model work better than that model, and which model should we use, and which is the one that has the best evidence? And instead we began to focus on what are those elements, what are those elements that have to be in place to help people move from the beginning of therapy all the way through therapy, and to do that in a way that they can enhance whatever model of treatment that you use. And so I think that becomes important because most folks have been focused on a model of therapy rather than how do you structure the movement across therapy, and where you could use any variety of models. The other danger, and I'm a real fan of evidence-based models, but the danger is that they're expensive to train. They're, in any organization, it's difficult to stabilize and sustain that knowledge base over time. So what you end up with is things that are practiced really outside of what makes them a best practice. And there's some inconsistency there, because a lot of time what's a best practice doesn't actually fit the system of care that it's operating in. And so all of this focus on in the best model to use misses the point. How do we have a relationship that starts people, moves them through the beginning, middle, and end of the process, so that a model that is appropriate to them and their situation can be applied and applied well. I think I answered that. Did I answer that question?
Yeah, no, absolutely.
Fully?
And you started to talk a little bit about your own approach, and I wanted to see if I could ask you a couple things about that. First thing would be bodifulness rather than mindfulness.
That's bodyfulness.
Bodyfulness? I was like, okay, can we do that one again? Okay.
No, that's fine. The mindfulness is kind of a raging popularity right now. It's a real trend. And there's a lot of really delightful, wonderful aspects of mindfulness. But one of the things that's kind of inculcated into the culture of mental health and has been around really a long time is this idea that emotions, thinking, and behavior are the fodder of therapy. And there's been kind of a removal of the body from that. Mm-hmm. Outside of sensory motor folks or people that do somatic therapies, most folks, they want to focus on these. The problem with this is that you don't have any of these. You don't have emotions, you don't have thinking, you don't have behavior that isn't generated through this body. And so one of the things that we help people understand is that the management of this, being able to keep this body relaxed, keep this body from getting dysregulated, and you will see changes. If you can achieve that, you automatically see changes in thinking, emoting, and behaving. So it's more of a bodyfulness focus rather than a mindfulness focus. It isn't the dedicated view of body that you would find in a somatic therapist, but it's basically an understanding that the body has to be considered and what's going on in the body. Because when the body changes its own chemistry through arousal, it changes what's appropriate behavior. Mm-hmm. And what we have done is seen a good amount of those behaviors as being pathological or intentional or willful, when they're really just the natural, predictable consequences, if you will, of having your body change. Mm-hmm. The challenge with this primarily is that most therapists have no training in anatomy and physiology. So it is interesting because they're so focused on the byproducts of this body without knowing why these would naturally occur if there's changes in this. Mm-hmm. And I think that disconnect interferes with the quality of health, the quality of recovery, the quality of understanding how to help people move through and be successful in therapy.
Absolutely. Also in your work you wrote, that a therapist's job is to get the parts of the mind working collaboratively in order to be integrated. Can you talk a little bit about this?
Yes.
A lot, I bet.
Would you like me to expound on that?
Yes, just a little bit more.
So, and when I work with kids, I explain it in some pretty easy ways that in order for people to be able to think clearly, to plan, to follow a plan, to look at their own behavior and kind of say, why did I do that, and make sense of it. In order to be able to do that, all of the parts of the brain have to be working kind of in an integrated way. Mm-hmm. And what happens when the body moves into a state of arousal, the hormones and chemicals that are produced by that actually interfere with this connection. And in a sense, it pulls those apart. And when it pulls them apart, only the most primitive pieces are the ones that become dominant. That that amygdala-driven limbic system, the primitive parts of the brain are driving this process. And so you don't get a nice integrated process. You don't get clear thinking. You don't get reality checking because the system isn't working in an integrated way. So if it's not working in an integrated way, a lot of the things that we see in the way of behavior, emotions, and thinking are absolutely what you would expect if they're not being able to connect well together, and you have a part of that brain in dominant control of all of the responses of the body. Mm-hmm. So part of what we really drive for when we're doing work, particularly with families, but in individual work as well, is to get those parts working well and collaboratively together, and to help people recognize the small changes in that so that they can intentionally keep this going. Mm-hmm. If they can keep this going, they're able to create more distinction, be more self-reflective, more self-evaluating. They're able to do a lot of reality checking. They're able to kind of regulate the degree of their own fear, and actually be able then to navigate and move through things more efficiently, which means that they're going to be more resilient overall. Mm-hmm. So being able to help people have this brain that works together becomes incredibly important. An easy example of this would be, you have a child going into a classroom, and the child comes into the classroom and they're already aroused. So the parts of their brain, if you want to kind of think of it this way, the right hemisphere and the brainstem are the ones that are dominant in that moment. Mm-hmm. Well, if those are dominant, this isn't going on. Mm-hmm. And so they don't have access to create distinctions in experience. They don't have the ability to self-reflect. They don't have the ability to kind of regulate their own behavior. And so the teacher sees that naturally correct physiological response to having the system being dominated by those two pieces, and then moves into trying to aggressively getting compliance and acquiescence to do what the teacher wants to have done. And you understand, it's not a blaming of the teacher, but it is a dynamic that sets the teacher and the student up for failure, because if the teacher can't get those systems to work well together, good learning is not going to occur. Mm-hmm. If the right hemisphere and the brainstem are dominant, you're going to have problems encoding memory. Mm-hmm. You're going to have, you're not going to be able to sequence data right. There's just a host of challenges with that. But what we do in the mental health world is we get focused on the emoting, behaving, and thinking piece, and think of that as the problem. Mm-hmm. Well, it is a problem because it's a natural consequence of having this system in a disconnected and aroused state. Mm-hmm. Yeah. And did that answer it enough?
Absolutely. And you kind of touched upon the next question as well. Aside from that, if not that, what are also some benefits that clients can expect when being seen by a therapist or a counselor that is trained in your approach or informed in your approach?
Well, if they're moving towards regulation first, which a lot of the organizations that are looking at core elements or what we call active ingredients, you want to educate them about what the body's doing. You want to make sure they have the ability to regulate themselves. They have coping strategies before you move into the more difficult parts of working with trauma. So what that does for a situation where you're dealing with a family is even a little bit more important, because the natural development of a child, if they're in an optimal environment, and a lot of the kids we work with are not in optimal environments, but if they're in an optimal environment, they should be able to be self-regulating and be able to do that kind of complex abstract thought, and be able to evaluate themselves more effectively somewhere between 11 and 13. So expecting that to occur with any kind of predictable regularity prior to that in an optimal environment is not practical. When you're looking at it in a suboptimal environment, it's even less so. Another way of looking at this would be that you can't ask a child to be more regulated than the adults in the child's environment. The most dysregulated person in the room basically sets the thermostat that heats, and the rest of the room will heat up to whatever that is. And so one of the things that this does is helps people kind of lower that thermostat and teach them the skills they need to keep the thermostat low enough that you don't have everybody else getting heated up as well.
Okay, awesome. And what challenges were you setting out to address when you were focused on your work with traumatized families?
One of the things that was primary to me was the lag between what the science is putting out there, and it's not just one piece of research, it's dozens and hundreds of pieces of research that establish this, and that practice wasn't changing to reflect what the science was saying. And that became an issue for me, because what I was learning, what I was understanding, what I was experimenting with, and kind of taking this research and applying, and I found, wow, that works so much. If I design things from this perspective, that works so much better than what I was doing before. And it became apparent that the gap between what we know, what's available to us scientifically, and what is actually practiced in clinics, there's this huge gulf. And that gulf to me was becoming more or less a social justice issue. It wasn't that we didn't know, as a profession, it's not that we didn't know what to do. It is that the people that were in charge of delivering that didn't have the knowledge to do it. They were operating on what everybody else did in their social environment. They were hearkening back to, they went to a workshop or they read a book, and they're trying to do those things. And they found some success with them at some point, and they're continuing to kind of move forward with that. But we have quite a bit of distortion. One of the things I ask therapists quite often is, well, what's your evidence that what you're saying is correct? And they look at me like, what are you talking about? One of the things we encourage people to do is to collect data on every session. Evaluate the data. Are you delivering the service you think you're delivering? And are you adapting what you do to fit the client more efficiently? And I think that there's kind of a global lack of that in a lot of treatment facilities. It's not universal. I mean, there are a lot of people that are really doing kind of an informed session where they're collecting data, they're evaluating the data, and they're using that data to then adapt to the need of their client and meet those needs better. But a lot of times what we find is the nature of the clinical environment doesn't support that. A lot of times we find environments that are more about encounter value or volume of service delivered rather than quality of service. So for me, that became an untenable piece. To me, it's an issue of justice. The people that need the help often don't have access to it, not because we don't know what to do, but because the people that are in charge of the mental health world and culture are not operating in what the science says we need to be doing. And I understand, that change is difficult for every organization. However, look at the way we do intakes in most mental health organizations. And yet, if you understand people that have histories of trauma, you should never access the history of the pain and misery until you have them have the ability to stay stable. What do we do on the intakes in a lot of organizations is plunge them right into this. We want details, and we basically go against, now 20 years of science that says we shouldn't be doing that, but because that helps them get a diagnosis that allows them to get paid for what they're doing. And so I have some dissatisfaction around that, because I think we're sometimes hurting people more because the systems of care haven't moved with the science of this field.
So it sounds like there's a big gap between what we've found and what we're actually doing. And it also seems like there is a gap between the people that are receiving the service appropriately and properly. Am I understanding that correctly?
I think so. I think that certainly the system issues are huge and complex, and we can make kind of suggestions of things that need to change, but it is really such an interrelated, complex system to change that I'm not being critical of it in this aspect of, why don't they do this? It is something that really requires intentional, deliberate thought in order to be adaptive to that. And I think that's that piece, that intention and deliberateness is missing from the systems of care quite often. The other piece I think is pretty accurate, is that a lot of what we are asking people to be able to do to move people through therapy was never part of any of their educational programs. Again, not because of any maliciousness or any lack of care, or these are really good-hearted people. They're being taught by people that are sincere and genuine. However, educational institutions generally design programs to help their people graduate and pass state exams to get licensed. That's not the same focus as saying being able to graduate and actually create change and improve population health. It's not the same skill set. And in most states, I think there's more or less and I almost hate to say that, kind of a driver's license mentality about counseling. So, regardless of the particular venue of it is, you go to school, you take the classes you need, you do the behind the wheel, you take the test, and now you can drive. And we treat mental health that way quite a bit. Well, if you're teaching to pass a test, that doesn't necessarily mean you're prepared to actually create change in people's lives. Because the things on that test are not the same things you're going to need when you're actually sitting down with another human being and you're trying to help them move through the history of their own adversity into a place of resilience.
So you've really dove into your work over the past couple of years. What would you say the favorite aspect of it has been?
Actually, it's been the last decade, not just the last couple of years. I think the last couple of years I've traveled a whole lot more. But the thing that I really just get a kick out of every time it happens is having somebody get that moment when you can see that they go, oh, that's how to do that.
That makes sense.
Or I probably get 8-10 emails a month from people that we've trained and that are putting this stuff into practice and saying, I didn't really know if this would work, and this is really helpful, or I had this case that I was really struggling with, and this really opened the door for that, or I'm practicing talking to clients in ways to keep them integrated in their brain, and how much work that is, and the results they're seeing as they're able to do it. Other people have kind of talked about, as they have gone through and re-looked at how they did therapy, and kind of eliminating those things that affect a movement away from this integration, and trying to actually increase that more and more as they move through therapy. That's been kind of exciting to kind of watch. And with anything, there's a lot of people that go to a workshop or a training, and they get one or two ideas and they leave and they go do that, and that's great. What just turns me on is the people that you can feel it almost from the very first time you meet them. These are people that want to have a mastery of healing. Mm-hmm. They want to master it. Mm-hmm. And there's a different feel to them. There's a different attitude. There's a different way that they ask questions. And when they begin to get it, mm-hmm. that's probably the most satisfying part of what I do.
Sounds like it's been a gratifying process so far.
So far, yeah.
So far?
Yeah.
Well, what do you want to achieve with this training? What is the end goal for you?
For this particular training, mm-hmm. the family training, mm-hmm. I really would like to interrupt the intergenerational transmission of trauma. Mm-hmm. I would like to have it be so that when they finish a course of treatment, that they have the skills to be resilient, because they're going to have other challenging things happen in their life. And I'd like to have the relationship be more secure. I'd like to have the relationship be more connected and solid and supportive. And frankly, I would like to see the consequences of having well-developed, secure families. The cost to our society, to our communities, the health costs are outrageous. The American Psychological Association published an edition in September, and where they are focusing on really relationship is clearly tied to public health, and in our society where that has not really been a focus for a while, we have tremendous amounts of public health issues, and the research would say that early developmental life, the earlier life relationships, actually set the stage for people to have chronic health issues in their 40s, 50s, 60s, and above. Mm-hmm. And to think that if we can divert that, if we can help that, then we not only help people have a better quality of life, but we have an opportunity to maybe lengthen their life, and we have the opportunity to have a public that has less chronic illness. Mm-hmm. And I think those are really admirable goals. Mm-hmm. No one can achieve that by themselves, and no one training is going to do that. But I think that's what our intention is to set the stage to have those changes take place.
Okay.